কাল্টিভেলটি করো কেন আমার সাথে?
Now, structure and functions of nephron, of course, I already told you, but still, let us repeat, you may understand better. A nephron consists of afferent and efferent arterioles, I showed you. A glomerulus, a Bowman's capsule, I told you. Proximal convoluted tubule, loop of Henle, and distal convoluted tubule, and collecting data, as I showed you here. You see, this is efferent arteriole, this is glomerulus, this is efferent arteriole, and this is Bowman's capsule, this is proximal convoluted tubule, this is loop of Henle, this one distal convoluted tubule, and this is collecting duct. This all together makes the structure of nephron. Now in the glomerulus there is a bed. It acts like sieve, chalun. Like chalni, it filters the water along with electrolytes and bad things, urea and creatinine, into the Bowman's capsule. And it takes back blood because if blood goes out, so the urine then will die. So the pore of the glomerulus is such that blood cannot pass. It is very small. So blood cannot pass. No albumin or protein will pass. Only water and electrolytes. So it brings back the blood and albumins and proteins, and only it allows to filter water and electrolytes and non-essential excreta like urea and creatinine. Now, essential electrolytes and most of the water I told you are reabsorbed into blood while passing through renal tubule. As there is 180 liter foam, and if it passes through urine, then will die. That's why most of these are reabsorbed to the blood. And remaining only 1.5 liter, 1.5 liter of fluid passes as urine. Let us proceed with it. Now we discuss about the function of the kidney. I think most of us have some idea about function of kidney. You see the good thing. Why in medical study we learn anatomy, physiology, pathology, then clinical subject. Why? Because in the physiology you know the normal functions of an organ, normal function. You know what kidney does in our body. If you know the function of the body, then you can have idea about the symptoms when kidney fails. So when kidney will fail or kidney will be diseased, it will lose its function. So you know that kidney excrete excess of water. Now if kidney fails, it cannot excrete the water, so water will be locked in the body and there will be edema, puffiness of the face, edema of the leg, there will be ascites, there will be pleural effusion. So you see, when you know the physiology of the organ, then you have the idea what will happen if there is pathology in the organ, if the organ is diseased. That's why you must learn physiology as well. So kidney has function excretory. Excretory means to pass out. It removes waste products from the body. Waste products, aborjona. It removes degraded drugs from the body. So waste products means what? Like urea, creatinine, and excess electrolytes. And degraded drugs, you see, drugs means allopathic drugs. Alhamdulillah, our homeopathic medicine, we cannot say that it is degraded in our body and pass through urine and liver as the allopathic does. No. But for allopathic drugs, these are crude drugs. They give in crude dose. So after it goes to the body, whatever work it will do, it will do. But afterwards, this drug material must be removed from the body. Otherwise, it will produce toxic effects. Now there are two ways of excreting the drug material from the body. One is through liver. You say, how through liver? It will go to the liver, liver will detoxify the drug. Then the drug will pass through bile into gallbladder. Gallbladder, it will go to the intestine and it will pass out to the stool. So this is one way of removing degraded drug material from the body. The other way is through kidney because the drug becomes soluble in it goes to the blood and it will circulate say one antibiotic. Say for example, one antibiotic, very bad antibiotic, say ceftriaxone, ceftriaxone, the third generation, fourth generation antibiotic. With this antibiotic, maybe the person has some abscess in the say abscess in the lung abscess. The allopathic doctor gave the injection, IV injection. So it will go to the blood. From blood, it will go to the lungs on the bacteria of the lung abscess. After fighting or after killing the bacteria, this will be if still it circulates in the body, then it will destroy our organs. So it must be removed. So what we'll do after it once is done in the lungs, it will go to the kidney and kidney will filter in the glomerular filtrate and passes in the urine. That's why there are some allopathic drugs. While it goes through the kidney, it damages the kidney. And one is this integrated ceftriaxone. If you give ceftriaxone in a child, yes, an allopathic can give, allopathic doctor can give on the in children, but that is a specific dose according to kg weight of the baby. Now one quack, he does not know the dose. Say he would think, okay, this is 200 mg for adult, let me give 100 mg to the baby. That he will give, maybe this baby has pneumonia, severe fever and cough and dyspnea. So if this quack gives ceftriaxone to the baby, and I will find after 2 weeks, the baby has swollen face and there is anuria, urine is not passing. What happened? It has damaged the kidney and resulted into acute renal failure. So kidney is one organ which removes the bad things, toxic things from our body. But sometimes it becomes it becomes victimized by these bad drugs. So one of the action you see, it removes waste product from the body and it also removes degraded drug material, allopathic drug material, or maybe Ayurvedic and Unani, those which are crude drugs from the body. Then it has regulatory function. But it controls body fluid volume. Now we say blood, we have blood, 5 liters blood. And this 5 liters blood, or say 5.5 liters blood, it must be constant. Your blood cannot be 7 liters. No, never. Then you will die. There will be rupture of blood vessels and there will be cerebral hemorrhage. There will be heart failure and you will die. So blood amount must be constant always. Maybe few hundred milliliter less or more, but not a liter. 5.5 liter, okay, no 7 liter. Now, if you take too much water, or maybe somebody gives you too much saline, all going to the blood. So, if our kidney does not work, just the person will die. Because this will increase his blood volume from 5 liter to 7 liter, and there will be all everywhere cerebral hemorrhage. There will be rupture of this and that, and the person will die. So you see, kidney is so important. If your kidney is okay, you can take any amount of water. You are free. Okay. It will keep only the fluid amount which is needed. And the extra things, okay, it will discard. So it controls the fluid volume. Fluid volume. Always. 5.5 liter of blood, because when you take, you see, you may ask how we take fluid and it affects the blood. Because when we take water, we drink water, we take Pepsi, we take this and that, all absorbed from the stomach and intestine and goes to the blood directly, and it will increase the blood amount, blood quantity. And when there is increased quantity of blood, our body knows that there is more fluid volume, more blood volume. Then it will ask the kidney, okay, you remove this excess, and kidney will filter this excess amount and make it urine. So it may control fluid volume, and also electrolytes. We are taking so much salt, this and that, sodium, potassium, magnesium, phosphate, carbonate, and our body needs some amount. But excess, no. If excess, body will react. If you have too much potassium is very limited range, from 3.5 to, say, for example, 5 millimole potassium in the body. If you have 7, 5 to 7, you'll die. Serum potassium cannot be 7, cannot be. 5 is too much. If 7, it will make arrhythmia of the heart, and heart will collapse. So if you take more potassium, you are taking, say, for example, more banana. You are eating bananas. You are eating so much citrus fruit, orange. So much potassium you are putting in the body. Now this will go to the blood, and it will increase the blood level. And if kidney does not excrete this excess amount of potassium, this blood level of potassium will increase from 5 to 6, 7, 8, and in that. So it is so important to keep your balance. Anyone to take, okay, excess will be out from the body, and they maintain their composition, composition of blood. Say there should be so much glucose, so much sodium, so much potassium, okay, in a nice balanced amount. So kidney is the one which makes this balance. So it is so important organ for our body. Now, what other action? Kidney has some endocrine function. If you say, if you are asked that, you tell me what are the endocrine glands in the body, many of us maybe they will forget that kidney is also an endocrine gland. Kidney produces some hormones like this. You see, this is called erythropoietin, very important. We'll discuss. Then renin, also very important to manage your blood pressure. This erythropoietin is very important to maintain your hemoglobin level. Then this prostaglandin and insulin and other things also. So kidney produces this thing, and these are very important for some things of our body. What I'll discuss. And by producing this thing, they control production of red blood cells. You see. This erythropoietin is very important. This erythropoietin is produced by kidney, and this erythropoietin stimulates our bone marrow. You know, our blood is formed from the bone marrow. So this erythropoietin will stimulate the bone marrow. Then only bone marrow will produce red blood cells. Otherwise, you will have anemia. So unless the kidney produce this erythropoietin, even you have so much iron in the body, you take so much iron in your food, or maybe you take as a tablet, still you will have anemia. Because your bone marrow will not produce blood unless kidney produces erythropoietin, enough amount of erythropoietin. So you see, so when the kidney fails, so erythropoietin will be less produced, and the guy will have anemia, and you will find kidney patient takes blood off and on. So this erythropoietin renin, yeah, controls our blood pressure. It regulates our blood pressure. This is very important also. This is its endocrine function. Now it comes metabolic function. Metabolic function like liver. You know, the Most important is metabolism of vitamin D. Now, let me little bit discuss about vitamin D production. You know, vitamin D we don't need to take from outside as a food. No need. Our skin has enough precursor of vitamin D. This is called vitamin D1. This vitamin D1 is activated by sunlight. If you sit for some time in the sunlight, sunlight will fall on your skin and will activate vitamin D1, vitamin precursor vitamin D to vitamin D1. Now this vitamin D1 will go to liver and liver will activate it to vitamin D2, and this vitamin D2 from liver will go to kidney and then kidney will activate it to vitamin D3. This is the final form of vitamin D, and unless there is enough vitamin D3 produced by kidney, your food has enough calcium, but all will go through your stool. This vitamin D will dictate our intestine to absorb absorb calcium from the food and drinks, and then this calcium will come and it will mature our bone, it will solidify our bone. So when there is kidney failure, this vitamin D3 will not be produced, only vitamin D2 from liver, and vitamin D2 has no function on calcium. Only after making this vitamin D3, D3 will dictate, will stimulate intestine to absorb more calcium from the food. If there is no D3, all calcium will pass through your stool. It will not come to your blood, and your bone will suffer. You will have osteomalacia, you will have osteoporosis, and your bone will break down, and you have hypocalcemia, and you will have chichari like this, all this. So you see, this is important. So there are other functions, but I give you here the important functions of kidney, that without this function we cannot survive. We will just die. So just from here you can guess, when a person has kidney failure, what complaint he will have and what problem he will have. Now we come to the renal failure. Renal failure means kidney fails to do its normal function. So renal failure means it denotes failure of the excretory functions of the kidney. If excretory function of the kidney is fail, then what will do? It will lead to retention of nitrogenous waste product of metabolism. Nitrogenous waste products means when the when we take meat after breakdown in the body, it will produce creatinine and urea, and these are toxic things which needs to be removed from the body, and this is removed only by kidney. So if kidney fails, this creatinine and urea will remain in the blood. It will collect on blood. And ultimately there will be too much creatinine, too much urea, there will be uremia. And the person will have uremic coma and will die. So when the kidney fails, one function is it cannot remove urea and creatinine. And also other functions will suffer like regulation of fluid and electrolytes. It cannot remove excess water from the body. When you take say about 3 liters or 4 liters of water, all the water or most of the water will remain in the body because kidney cannot make enough urine. So you will have edema, you will have anasarca, you will have pleural effusion, ascites like this. And electrolytes, I told you, kidney also removes excess electrolytes. So there will be more potassium. I told you already. If potassium is more than 5, 6, 7, then you will die. For nothing else, only from hyperkalemia you will die. Because it will destroy your cardiac function. there will be cardiac arrhythmia and failure. So all the potassium, sodium, calcium, phosphate, magnesium, they will be all imbalanced in the body. And also endocrine function. If you lose the endocrine function, what endocrine function? I told you that there is erythropoietin. It produces erythropoietin. You see, this erythropoietin. So there will be no erythropoietin, and there will be no stimulation of the this is called bone marrow to produce blood. So the person will have anemia and anemia. He may have say 10 gram, then he will have 7 gram, then he will have 5 gram, and 3 gram, and he will have anemic heart failure, and he will die. He will die. He will die not of kidney failure, then he will die from heart failure. You see, and why this thing happens? Because kidney is not producing enough erythropoietin. So just you can guess that what will happen when kidney will fail, when kidney will refuse to do its function. Now this kidney failure we can categorize, we can classify into three categories. One is called acute renal failure. Acute. One is called chronic renal failure, and another is called end stage renal failure. In the for this class today, I gave one post in Facebook, and I put the term in Bengali as well as in English. So chronic kidney failure, I translated into Bengali, chiro brikko karjo ব্যর্থতা বা something এই ধরনের something like this. And in bracket I wrote chronic renal failure. Chiro means chronic, বৃক্ক কার্য ব্যর্থতা. Now I find one guy, he was very angry. He gave me a good rejoinder. Oh, how can you uh, translate everything in Bengali? Why medical subjects should be taught in English? This is a funny post he gave, and he was so angry. Why? I wrote, but I wrote both English and Bengali. Chiro, বৃক্ক কার্যব্যর্থতা and chronic. Okay, if you have good translation, better translation than me, then you tell me like this. He did not say. He only say, no, this is funny. He said, I wrote funny. Then I was a little bit angry, but because I am old man, I controlled it. Then I gave one good answer also. You can see in our post. I told that because to learn medical science and medical subjects in our mother tongue is a good thing. Yes, this is a very encouraging thing. I told him that you see the Russia, China, Spain, Germany, France, Portuguese, Greek, are they learning medical subject in English? No, they learn in their own language. I went to China and I find that Chinese people are learning all their own language, and they are not bad doctors. They are good doctors. So yes, because we were ruled by British people for 200 years, that's why we learned English. It's okay, and we are also learning medical subject in English, but at least we should try little bit to give our education in Bengali also. And I told him that you see, in later part of the 19th century, this from 1850, this in Indian people, many they learn homeopathy in English, but they wrote book in Bengali, like Radha Raman Vishwas, like Nilmani Gotov, like B.K. Basu and other things. And from their works only, many of our homeopaths, they learn homeopathy. And now we are getting this homeopathy from their hand. So if they did not write books in Bengali, only few people, few learned people would be able to learn homeopathy in English, but not all. So this is the thing. That's why you see, we in our class, in one class we give English lecture, okay. In another class we give Bengali lecture, because if we give only English, then we will find that many of our colleagues, they will be unable to learn. So renal failure is categorized into three categories: acute renal failure, chronic renal failure. But now we'll discuss one by one. First, acute renal failure. Acute. Acute means ochiro or tatkonic, what you say. It refers to a sudden and usually reversible loss of renal function, which develops over a period of days or weeks. So acute renal failure, if this development is sudden and it is reversible, it will come back to normal by itself. And it develops only over a period of days or weeks, not for a long time. That's why you tell it acute renal failure, because it is being produced in a short time, it is reversible, that's why it is acute renal failure. And when we find the serum creatinine in such patient goes beyond 200 millimole or 2.25 milligram is creatinine, then we say this is acute renal failure and we start treatment. Now let us discuss a little bit about causes of acute renal failure. What are the causes of acute renal failure? Maybe most of us, our homeopathic doctors, we find less cases of acute renal failure. Why? Because most of the acute renal failure goes to hospital. Only little come to us. What comes, in my experience, most case of chronic kidney disease, chronic renal failure. Acute will get less, but still we must know acute because you may find, I find some cases. So now what are the causes of acute renal failure? We can divide the causes into three. One is pre-renal, renal, and post-renal. Means pre-renal means before before kidney. The cause is uh, before kidney is involved. And renal means it is due to renal problem, renal disease, kidney disease. Post-renal means the kidney is okay, but there is some problem after kidney. So pre-renal, one is systemic, like heart failure. If a person has severe heart failure, so this heart failure, you will have less pumping of the Dr. Anwar. You can deal with this guy. I think you remove him. You remove. Yeah, yeah. Okay. So, so pre-renal means before renal. Means if the person has heart failure, his kidney is okay, but he has heart failure, or he has severe blood loss or fluid loss. Say a person, a woman, after giving birth, she is losing too much blood, blood and blood. Or a person having too much vomiting of blood for something for from gastric ulcer, or he has so much blood from his rectum, then by this blood loss, he will have shock and it will affect his kidney. If a person has too much diarrhea, cholera, he is vomiting and purging his stool, then there will be fluid loss and there will be hypovolemia, and the kidney will find little blood to pass through. So kidney cannot remove the waste product from his body. There will be more creatinine, more urea, and there will be electrolyte imbalance, and the person will have acute renal failure. Then there may be renal artery stenosis. I told you renal artery, sometimes there is stenosis of the renal artery. If there is stenosis or there is occlusion by the same thing as our cardiac coronary artery becomes occluded, renal artery can become occluded. If both kidney artery becomes occluded, then he will have renal failure because the kidney will not get any blood and it cannot remove any water or electrolytes from the body. So there will be acute renal failure, sudden renal failure. And there are some renal disease which may cause also acute renal failure, like glomerular disease. You see, there will be glomerulonephritis. There will be acute tubular necrosis. These are renal disease. And there are something extrarenal, like renal stone. A person has bilateral uretary stone. You see. So both the ureter becomes blocked. If they cannot pass urine, and there will be break pressure in the kidney, and it will jeopardize the function of kidney, and kidney will fail. Or there may be tumor. Some tumor press on the ureter and blocks the ureter. So ultimately there will be back pressure to the kidney, and kidney will fail. So this is called post-renal. So these are the causes of acute renal failure. So you see, when you treat acute renal failure, so you must treat the cause. You must remove the cause. Then only the case will improve. Now, how can you know there is acute renal failure? What are the clinical features? What are the signs symptoms? It includes causal condition like okay, you see, there will be oliguria. You find the patient passes very little urine. If he passes less than 500 ml urine per day, less than half liter, we say this is oliguria. And if he says, I never pass urine last 24 hours, this is called anuria, that no urine. And little urine is called oliguria. So when there will be renal failure, say a person was having too much vomiting and diarrhea, then you find that suddenly he stops urinating, no urine. So this is one sign of renal failure, acute renal failure. Then you will be having some other symptoms I'll tell you afterwards. And if you check his blood urea and creatinine, you will find his creatinine is too much high, and his electrolytes, his potassium will be high, maybe sodium will be less, and there will be acidosis. So you can diagnose as acute renal failure. I'll tell you the symptom also. Yeah, then when this creatinine will be more, potassium will be more, what will happen? He will have anorexia, nausea and vomiting. The person will find he is have nausea, he is vomiting, and he is drowsy, apathy, confusion, muscle twitching. Then you know that he is going to have acute renal failure. A lady, after giving birth, she is having too much bleeding, postpartum hemorrhage, and then find that she is not passing urine, and she is drowsy, and she is, say for example, confused, and there is muscle twitching, she is vomiting. So you must have in mind that she developed acute renal failure due to excess blood loss. Now, how can we manage a case of acute renal failure? You find a case came to you that he had diarrhea, too much diarrhea or maybe cholera, and he developed renal failure. Or a person, by some accident, he lost so much blood and he developed acute renal failure. How can you diagnose? You will have to see the clinical features and you measure his creatinine, urea like this, and electrolytes. And this will tell you that he has acute renal failure. Its management is easier. I can say a homeopath can manage, a homeopathic hospital can manage a case of acute renal failure. How? So, its treatment is simple. First, you must find out the cause. What is the cause of acute renal failure? And you try to correct this one. If he has too much bleeding, you try to stop his bleeding by some way, by stitch or by bandage or something. So once blood is going and going, you cannot treat his acute renal failure. So you must treat the cause first, number one. Second thing, you give him bed rest. Then you will have to control his fluid and electrolyte balance. He lost so much blood, then you will have to give him blood. He lost so much fluid by diarrhea and by vomiting. You will have to give optimum amount of intravenous fluid and electrolytes because he lost this thing. And all drugs, particularly non-homeopathic drugs, must be stopped or if it is very much needed, it must be taken off this uh, expert opinion. If it is needed too much, you cannot give it. Better all drugs should be stopped for the time being. Then, how much fluid, once he is resuscitated, say he lost too much fluid, you gave him say about 1.5 liter, 1.5 liter of fluid, and you find that his pulse and blood pressure is now okay. Now he will maintain his fluid every day. How? So you will have to put one condom, if a male, a condom catheter to collect his 24 hours urine. A female one, this is called self self retaining catheter to collect the urine, because unless you collect the urine, you don't know how much she is dosing. So you add 500 ml fluid with the amount of urine. So if you find that the guy passed 500 ml of urine by 24 hours, then you add another 500 ml, means 1 liter for 24 hours to this person. Like this way, you will have to maintain his electrolyte and fluid balance. Then he cannot be given more potassium containing uh, fruits or something like this. You cannot give him banana, you cannot give him a citrus food like orange and something like this. Then you must restrict his protein intake, protein and energy intake. So his protein must be restricted to maximum 400 gram per day. A small piece of chicken chicken leg, say for example, 400 gram only per day. You must restrict the protein very much. And if you find after some times his urine output must be better and better. You find that his urine yesterday was 500 ml, today it was 700 ml, then other day it is 100 ml, 1000 ml. Then you find that he is improving. His condition is returning. But after a week or 5 days, you find that his urine output is not improving. His creatinine is going higher and higher. Then he must be sent to renal replacement therapy like dialysis. Otherwise, he will die. Otherwise, he will die. You do, it is called conservative management. And allopaths also, they do the same thing in the hospital. Because nowadays, so many dialysis available. While we were student in 70s, 80s, dialysis machine was not available. That time, the allopathic consultants, they were doing this, what I say, this conservative management. So you find many of the patients, they recover by this conservative management. But for our homeopathy, this is good. We can give homeopathic drugs because it does not affect his kidney output or something like this. So you can give according to his totality of symptoms similarity, you can give him what is needed. Maybe epocidin, maybe a piece, maybe say for example China. What is needed according to his symptoms, you can give, and it will stimulate his kidney function. But allopath has no medicine to stimulate his kidney function. There will be just observation of the patient and making the fluid balance, restricting his salt and protein, this and that. And if God helps the patient to recover. Otherwise, he cannot do anything. But we homeopath, we can give positive drugs according to his symptom, and we can stimulate his body and kidney to function back. So this is the management of acute renal failure. And as I told you, we don't get acute renal failure. I say we don't get. Sure, I'm sure most of our homeopathic colleagues here, they will agree that they did not manage a case of acute renal failure, because acute renal failure needs to be admitted, and you cannot cure him by 1 day, 2 days in medicine. You will have to observe him for 1 week, 2 weeks like this. That's why acute renal failure is not our problem. This is hospital problem. Actually, the patient mostly comes to us, they are chronic renal failure. Now we are going to chronic renal failure. So this is chronic renal failure. This case, they come to us. And you find, I'm sure, many of our colleagues are getting more and more kidney failure patients nowadays because when there is chronic renal failure, the allopathic nephrologists they have set programs for dealing with this chronic renal failure. They will give some medicine only to maintain his condition. Allopathic they have no medicine to lessen, to cure this chronic renal failure once it starts. They will only give medicine to delay his progress to complete renal failure. To delay. Maybe okay, he would have gone through total renal failure by 1 year. Okay, he will delay it for 3 years, 5 years like this. This much only. But if these people come to us in better time, in early stage, homeopath can cure this patient to his previous state. Of course, if they come in later stage, we cannot cure. And mostly we can only help them by giving palliative medicine. But if they come enough early and it is in a reversible stage of kidney, yes, we can treat them to full cure. So let us now discuss about chronic renal failure. Chronic renal failure implies long-standing and usually progressive impairment of renal function. This renal function will be impaired, will be less and less gradual over the time. And in many instances, no effective means are available to reverse the primary disease. This is for allopathy. In most cases, allopathic nephrologist, he does not have enough drug to cure it or to reverse it to the normal. As I told you, he can only delay its progress to complete renal failure. When death is likely without renal replacement therapy, it is called end-stage renal failure. So ultimately, a patient suffering from chronic renal disease, chronic kidney disease, he will attain a stage his case cannot be reversed unless treated with dialysis or replacement therapy, he will die. So this stage is called ESRF, end stage renal failure. Now, let us see here what are the causes of a chronic renal failure. Why chronic renal failure occurs? Why? If we know the cause, it will help us in the treatment of chronic renal disease. So first you see, there are some congenital cause, Janmagoto, from his birth problem. What is this? So if he has polycystic kidney disease, I think many of you might know it. Polycystic kidney disease. What is this? A person may have from his birth, his kidneys is like having many cysts, like polycystic ovary, in the female patient, we say PCOS, polycystic ovary syndrome. So here in the kidney, there are so many cysts. It's like mousak, moumasil chak. So many cysts and making the kidney very big. So if it is congenital. So this polycystic kidney disease will kill his kidney gradually. It will destroy his kidney tissue. The cyst will be bigger and bigger and it will go on destroying his kidney tissue and ultimately his kidney mass will be less and he will have end-stage renal failure, dialysis or he will die. One of our homeopathic board high official, I'm not going to say the name, you as our good colleague, is you can say second highest board official for a long time. Even while I was student in, he became in that he went to that post maybe in 1980. Yes, I think. So he had this polycystic kidney disease, and he died by this time. And I know because he came to me. He told me that he was said, sometimes people do not want to divulge his problem, but he told me that I have this disease and my creatinine is going high and high, high and high. What to do? I gave him some suggestion, but he went to abroad. He went to abroad, and he tried there also, but nothing happened. He came back and he died in Bangladesh. So also we have many patients. I have say about 5, 6 patients, polycystic kidney disease. They come to us. So this one, 5%. 5% case of chronic renal failure by polycystic kidney disease. And here, actually, we have very little to do. Most of the time, polycystic kidney disease, the case does not respond because the patient became adult, and what kidney should be destroyed, it has been destroyed already when they come to us. His creatinine is going higher and higher. Ultimately, he will develop renal failure. Okay, second thing, renal artery stenosis. I told you there are two renal artery from the aorta going to kidney. And as we have coronary block, coronary artery block, same thing, renal artery can be blocked by atherosclerosis or maybe congenitally. So if there is both kidneys, because if one kidney has renal artery stenosis, there will be no kidney failure because one kidney enough to continue your body function. So if bilateral renal kidney stenosis, renal artery stenosis, there will be chronic renal disease and renal failure and patient will die unless they reverse the condition. So this is 5%. Now we come hypertension and diabetes. These are the two most killer disease for chronic kidney disease. Hypertension has about 25%. If you find a case of chronic disease, very few cases you find that he has blood pressure normal. Very few. Most of the case, maybe 80% or 90% maybe, you find he has high blood pressure. So this high blood pressure for a long time, if untreated, some people has a high blood pressure, he does not mind, he does not take treatment. Then they will have chronic kidney disease and renal failure. Then you come diabetes mellitus. Diabetes mellitus. 40%. This is the most killer disease of chronic kidney disease. Many patients having diabetes mellitus and he is not caring much for its treatment. And you will find that his creatinine is going higher and higher, higher and higher. And ultimately he will develop CKD, chronic kidney disease and renal failure. So these two, hypertension and diabetes mellitus, are major killer of chronic kidney disease. Then there are some other issues, some inflammatory disease, some intestinal disease. So we'll find most cases these three cases. Polycystic kidney disease we find, then you find hypertension and you find diabetes mellitus. And there are some cases like chronic glomerulonephritis. This is kidney disease by itself. A person having nephrotic syndrome, there are diseases called nephrotic syndrome. So if he has nephrotic syndrome by itself, not by hypertension, not by this and that. So nephrotic syndrome, unless it is treated well, and nephrotic syndrome can be cured only by homeopathy. By allopathy, no. They will only control and it will go on towards chronic kidney disease and renal failure. So these are called interstitial disease. This is 5 to 15%. Glomerular disease 10 to 20%. So means another 35% case by originally kidney disease, and 40% by diabetes and 25% by hypertension. You see, these three major cause of kidney failure. Glomerulonephritis number one, then hypertension, and then diabetes mellitus. So if you have diabetes mellitus or hypertension, be careful to control your uh, hypertension and diabetes to optimum level. Otherwise, you will have chronic kidney disease at the end. Now, what will be the feature of chronic kidney disease? How you know that this guy has chronic kidney disease? This is very important. Otherwise, unless you know the clinical feature, you cannot diagnose, you cannot suspect that this guy has chronic kidney disease. Only if you can suspect that he has chronic kidney disease, then you will make some investigation which will say that he has chronic kidney disease. Otherwise, you cannot. So, the early stage of chronic kidney failure are often completely asymptomatic. You find that many of the chronic kidney disease patients, chronic renal failure patients, they are diagnosed accidentally, suddenly. They came for something else. They came for some other disease. Then the doctor wrote, say for example, only urine for RE. I told you in my last lecture that every patient comes, if he is aged one, please make two tests. Anybody say, okay, this guy is taking money from pathology? No. It is your duty. Write one CBC, blood for CBC. This will give so much information to you about the patient. And write one urine for RE, urine for routine examination. This will give you so much information. So maybe this patient came, you wrote for him urine for RE. Then you go, oh, he have so much protein, 3 plus proteinuria, and there are casts. Then it will raise your suspicion, oh, why this guy has proteinuria? Then only you write, okay, go for again, serum creatinine, blood urea, and electrolytes like this. Then you know his condition total. Then you make ultrasonography, this and that, and you know the whole diagnosis. So most of the patient comes completely asymptomatic. He doesn't know that he has kidney disease. It may often present as a raised blood urea on creatinine, you see, found during routine examination, as I told you, often accompanied by hypertension, proteinuria, anemia like this. So whenever a patient of hypertension or diabetes come to a qualified physician, you will keep in his mind that this guy may have some problem in the kidney. So any patient hypertension for a long time, diabetes for a long time, even if he does not complain about his kidney, you must check his kidney function by writing a small simple serum creatinine. Plus, this serum creatinine will give you so much information about his kidney condition. So when renal function deteriorates slowly, the patient will remain asymptomatic until GFR is 20 ml. You see, one is called GFR. What is GFR? We'll discuss afterward what I tell you. One is term GFR. You must know, you must keep in your mind very, very sound, because unless you don't know GFR, you cannot diagnose chronic kidney disease and you cannot evaluate. This is called glomerular filtration rate. It means how much of this kidney, how much blood can be cleared of creatinine by this kidney in 1 minute. This is the ability of the kidney to clear blood from creatinine in 1 minute. Normally it is 80 to 100 ml. It means, say for example, my kidney will clear 120 ml of my blood per minute, clear of creatinine. So this is the ability of your kidney. If it is less than 60, then it means your kidney has become compromised. It is going to renal failure, chronic kidney disease. And if it is less than 15, okay, you can declare that this guy has renal failure. If it is less than 15. So GFR is a very important parameter to assess and evaluate your kidney patient. So even you see, unless the GFR is below 20 ml, still they remain asymptomatic. That's why this is always better for old people like us, more than 60. Okay, you don't have symptoms, but still you make a routine examination of lipids, sometimes only one urine, RE, blood for CBC, and one ultrasonography, and maybe one ECG. That's these four. These four will give you a good checkup every year. So then the first symptom the patient will notice This is called nocturia. The patient will say, I have, okay, uh, normal duration in the daytime. But night, oh, too many times, even before going to bed and even after sleeping. I'll have to wake up and go to bathroom for long, many times. This is called nocturia. More urination at night. This is the first symptom. It will knock in your head that you are going to have chronic kidney disease. So be careful. Nocturia is the often the first symptom which will knock you that you are having chronic kidney disease. So this is due to loss of concentrating ability of the kidney. Thereafter, due to widespread effect of renal failure, symptom and sign may develop related. Okay. After this nocturia, so when the nocturia is established in a chronic kidney disease patient, then very soon he will have other symptoms also. So first symptom is nocturia. Now, what other symptom? What other symptom? Before that, I tell you, when nocturia will be first sign, then kidney function, you know that kidney function is deteriorating. And you will have to measure his serum creatinine and GFR. Now you will get other symptoms. Nocturia, then what? Then anemia. After nocturia, this person will have anemia. Why anemia? We already discussed something. You see. Why anemia? Why anemia occurs in chronic disease patients? If I am a teacher, I will ask my patient, ask my students. You will have to answer like this. That anemia is erythropoietin. Why this guy sounds in. So anemia is really common and correlates to the severity of renal failure. If anemia is too much, you must think that your renal failure is too much. Say you have only 10 gram hemoglobin, and if you have chronic renal disease, it means it is little. But if you have 7 gram hemoglobin, you must think that his chronic kidney disease progressed so far. So level of anemia often dictates the level of chronic kidney disease. And why it happens? It is happens due to relative deficiency of erythropoietin. I told you that kidney produces erythropoietin, which is responsible to stimulate our bone marrow to produce blood. Now the kidney disease hampers this erythropoietin production. So there is no erythropoietin or less erythropoietin. So there will be anemia. Number one. Second thing, diminished erythropoietin due to toxic effects of uremia on bone marrow. Also, this is one thing. And another cause is due to uremia, because this guy has more urea in the blood, this has toxic effect on bone marrow. So it hampers bone marrow to produce blood. Then reduce red cell survival. You know, RBC survival is 120 days. Once one RBC is born from the bone marrow, it will live up to 120 days, means 4 months. 4 months. After 4 months, where it will go? It will die. Where? You know, RBC has some grey word, like our Azimpur Gorostar, grey word for us. Now, RBC has one grey word, Gorostan in our body, where sure, most of our students know this is spleen. They say when RBC becomes old, say it is having maybe 115 days already. He has 5 days remaining to die. Then they themselves go to sleep and they die there by mistake. So when there is chronic kidney disease, this RBC survival will be less. It will not survive for 120 days. Maybe it will survive 90 days. So there is anemia. This is another cause. Then reduce dietary intake and absorption of iron and other hematocrits. Because when there is chronic kidney disease, he will have anorexia, loss of appetite, and his indigestion. And he will take less food, less iron, less absorption of iron, and anemia. So you see, so many factors contribute to the production of anemia in chronic kidney disease. So if you find a chronic kidney disease patient, you ask him about nocturia, whether he passes more urine and frequent urine at night, and then check his anemia. Uh, I think we keep this for another day. I think long discussion with many people became already annoyed. So, inshallah, next day we'll discuss about clinical features of chronic kidney disease, and then so many things, and then renal failure, and then treatment, dialysis, peritoneal dialysis, and then homeopathic treatment. I think it will take another 2 days. So, who are present today, I ask them, don't miss this class. Just don't leave. Because it is, I am not boasting, but only I say that there is no other person in our amongst us who will give you this lecture. It's a good thing that I took enough trouble. It took 1 month for me to prepare this lecture, so that I find, because these questions are more commonly now coming to our homeopath, and some are treating like as he likes. So we want to give a correct perspective and good line of treatment so that it will help him in dealing with his patient. So please don't miss the class, and also I tell you, you tell your colleague to come to the class so that they know this is English class. I hope you understand my poor English, and also we'll discuss it the same thing in Bengali afterwards. It is better for you if you stay in the English class as well as you stay in the Bengali class, so you will understand better. And I hope some DHMS students and doctors, I invited them through some people. I don't know if they are today present here. If they are present, sure they will be benefited. If not, sure they will be. So if any DHMS doctors here or student here, I ask you to invite your colleague to attend this class, because it's a good thing and they should know about chronic kidney disease, chronic renal failure, end-stage renal failure, dialysis, and how kidney transplantation is achieved, and what to do if a transplant patient comes to you for treatment of other things, and what is the homeopathic approach. This is very, very important class. So with this, I end here my lecture, and thank you very much for patient hearing and giving your valuable time to our class. And as I told everybody, today there was a standing committee meeting of our Bangladesh Homeopathic Parishad, and we decided the participant who will be present in our class, more than 50 classes, more than 50 workshop classes in this year, from January to next January of 224, will give you an attendance certificate as continuing medical education. So I think this is not bad if you find a certificate from poor people like us, and not from us. This is from our association, and this is the oldest association of homeopathy in Bangladesh, which promotes classical homeopathy. So I am inviting you to attend the class throughout the year, and sure we'll bring many subjects for you, many subjects. Maybe many subjects you never learned in your class. So you'll find so many things we will bring in our classes, international subjects and useful subjects. So I invite you again to attend our class, and I am now ending here. I am giving the microphone to uh, our entrepreneur, Dr. Anwar. If there is some question, maybe question will take more at the end of the two classes, but still I'll take some of your question today. So, Dr. Anwar, I'm ending here. Okay, Assalamu alaikum to all.
থ্যাংক ইউ ভেরি মাচ স্যার, আপনার অত্যন্ত গুরুত্বপূর্ণ প্রেজেন্টেশনের জন্য এবং চমৎকার প্রেজেন্টেশনের জন্য। আজকের উপস্থিতি যারা এখন পর্যন্ত আছেন আজকের ক্লাসের উপরে যদি আপনাদের কোনো মন্তব্য বা সাজেশন অথবা কোনো প্রশ্ন যদি থাকে আপনারা করতে পারেন। আপনি ইচ্ছা করলে বাংলায় অথবা ইংরেজিতে আপনি যেভাবে ইচ্ছা সেভাবেই আপনার প্রশ্নকে উপস্থাপন করতে পারেন। আর হ্যান্ড রাইজ করলে একটু সুবিধা। আমাদের মোহাম্মদ আব্দুল হান্নান, আপনি হ্যান্ড রাইজ করেছেন, আপনার মাইকটি আনমিউট করে প্রশ্নটি করবেন।
Assalamu alaikum warahmatullahi wabarakatuh. Many thanks to our senior and respectful Dr. Sheikh Faruk here, sir. A good discussion for a physical function at the CKD, chronic kidney disease. We have many learn here. As a participant, we are very proud of our sir. Sir, I have a question that you discuss about the kidney function and any part of the kidney function. Sometimes some people or some patients come with us that they have in the first time of urine, during urine and end of urine, they feel burned, and sometimes blood, the synuria, comes with their urine. What is the dysfunction or of this cause? And another question, sir. You explained that when our blood increase 5.5 liter to above up to 7, how the blood increase in our body, and what is the reason of it? This is my question, sir. Thank you, sir.
Your first question, I understand that you said there is pain during, before, or maybe when not urinating. What is the cause? This may happen during, this is called UTI. Sometimes urinary tract infection. If there is fluid infection of urinary tract, then people have irritation in the bladder. And when the urine passes, there is pain. So pain may be before, during, and after urination. So this is one thing. And again, maybe no urinary infection. Only the guy takes less water. His urine is concentrated, and this can also give him a sense of burning of urine. Okay, for your second question, I forgot what you said. What
Sir,
you said
blood.
again?
How the blood comes?
Yeah. Yes, I understand. Blood, you see, you cannot have 7 liter. Maybe from 5.5 liter to 6 liter only. Then your body, there is automaticity in the body. God has given our body an automaticity. All our organs are coordinated with each other. When there is too much water volume or blood volume, how blood volume increase, as I said, when we take drinks, water and other drinks in our body, it goes to our stomach and intestine. And these are absorbed into the blood vessels. And it goes directly to the blood. And it will increase the blood volume. And whenever there is increased blood volume, it will dictate the kidney to pass the excess water in the form of urine. So you cannot make your blood volume 7 or 8 liters. You can never. So there is automaticity in the body. So body will pass this excess water as urine. So you will have only 5 to 6 liters and not more than that. Okay, thank you.
Yes, sir. Anyway, thanks to you. About the discuss about the filter of our body, the kidney. I hope may Allah long life you. Thank you, sir.
থ্যাংক ইউ ভেরি মাচ। ডক্টর মোহাম্মদ আকবর হোসেন, আপনার মাইকটি আনমিউট করে প্রশ্ন করুন। ডক্টর আকবর হোসেন, শুনতে পাচ্ছেন? আপনার মাইকটি আনমিউট করে প্রশ্ন করুন।
Gastric dialysis can cure by homeopathy, please.
I think I'll answer it. at the end, because we'll come to this point when the patient will go to dialysis and how dialysis is done and what is kidney transplantation. For that class, we keep this question. So you will enjoy and other will understand. Okay, thank you.
Thank you very much. Dr. Mizan.
জি, আসসালামু আলাইকুম। আমি জানতে চাচ্ছি পলিসিস্টিক কিডনি ডিজিজের লক্ষণ কি এবং এর কোনো হোমিও ট্রিটমেন্ট আছে কিনা অথবা কোনো সার্জিক্যাল প্রয়োজন হয় কিনা?
That's good. Their locon is usually it will produce symptoms only when it will cause chronic renal failure. Otherwise, only if you say it is objective symptom, sign. When you will examine kidney, so there is a procedure how to palpate kidney. Then you will find there is a bigger kidney. So the patient will not tell you. Or maybe if it is too big, patient may find himself there is some solid structure on my loin. And when you examine, you find it. This is one. This is a sign. This is not subjective symptom. You will develop subjective symptom when he develops chronic renal failure. Otherwise, this is asymptomatic. Number one. Secondly, its treatment is difficult, I tell you. Its treatment is difficult because it is an established case since his birth. And now, by giving medicine to reduce it to its original size, it is very difficult. But by our homeopathic treatment, you can manage his condition to acceptable level. Because most of the patient comes to us, we find that his creatinine is going higher and he will have some symptoms. Maybe he has some edema in his body, he has already puffiness and there is anemia. So with this we can manage his case. But to treat a case of polycystic kidney disease and to make it just normal kidney, this is very difficult. I don't say it is impossible, but this is very difficult.
And another question: is there any relation for hypertension with polycystic kidney disease?
There is no relation that if he has hypertension, he will have polycystic kidney. No. Only thing, when the polycystic kidney will go to chronic renal disease, then it will develop hypertension. Otherwise, not. Thank you.
Okay, thanks.
থ্যাংক ইউ ভেরি মাচ। আর কারো কোনো প্রশ্ন থাকলে হ্যান্ড রাইজ করুন, আর না হলে আমরা আচ্ছা ডক্টর শিবির আহমেদ স্যার, স্যার আপনি আপনার প্রশ্ন করুন।
Sibir, I tell you, Sibir
শিবির
Ahmad,
আহমেদ স্যার,
I think
স্যার মাইক
most of you know him. He is a professor, senior most professor of Sylhet Usmani Medical College, and we are happy that he is now converted to homeopathy and he practices homeopathy free for many poor people. He is a very good promoter of homeopathy. So we thank him very much. Okay, Dr. Shibir Ahmad, Professor Shibir Ahmad.
শিবির আহমেদ স্যার, আর শুনতে পাচ্ছেন? স্যার আপনার মাইকটি আনমিউট করে এই প্রশ্নটি করবেন স্যার। কোনো কারিগরি সমস্যা হচ্ছে মনে হয় স্যার। স্যার আপনি কষ্ট করে যদি ডিসকানেক্ট হয়ে আরেকবার রিজয়েন করেন ভালো হবে স্যার।
Hello.
Hello.
স্যার শুনতে পাচ্ছেন?
Shibir.
Okay, thank you. I forgotten to unmute it. Anyway, so thank you very much, Faruk bhai. Every time is something very precious to hear from you. So it's a wonderful lecture. Wonderfully much to say. It's better than any nephrologist. I must have to say. It's better than any nephrologist. So you touch almost everything, so elaborate and pick I say, pick up the lecture, two things that you have mentioned. So, one thing, any the senior citizens, more than 50 years, we need to do this urine test and blood test. And this is the subject, CKD, chronic renal disease. Number of patients for dialysis. So we are running dialysis center. We know the patients increasing day by day, and the incidence of diabetes and hypertension. Unfortunately, it is most of the patients they are suffering from diabetic nephropathy. They come for dialysis. So renal failure contributing factor said diabetes and hypertension. So we need to do the tests frequently, at least periodically once a year, and treating diabetic patient, say homeopath or say modern, so allopath physicians, we should not forget to do the creatinine test. That's one thing I learned from it. Many times we miss it. So day after day, month after month, we are treating diabetic patient, hypertensive patient, but we forget to go for the creatinine test. This one of the peak. The other peak that you have mentioned, nocturia, and then gradual development of anemia. So this nocturia, many of us we take it maybe say for UTI or say simply for diabetes. So someone is suffering from nocturia.
or maybe prostate. Some people will think it's
Yes,
prostate.
maybe prostate. But it has a direct correlation with CKD. We forget it. We and many times we miss it. Many times we miss it. Our patients suffer. So I got this insight from your lectures. These two very important things, and I do believe these two things are going to be a very of huge importance to all the practitioners, and definitely the practitioner from the practitioner that patient will be benefited. Many one in early stages we can detect the chronic renal diseases, and not many kidneys will be saved, many lives will be saved. That I can say. So, and in allopathic medicine, the treatment of CKD, it's dialysis is not the solution because people are going for we say, okay, well, you have started dialysis, so it's not too long that he's going to die. Because first, say it maybe once in a month, then twice in a month, then say once in a week, then twice in a week, then say every alternate day. How many? They are getting poorer and poorer with this dialysis, but it cannot save their life. And the symptoms, even with dialysis treatment, the symptoms remains. They cannot have a quality life. They cannot have quality life. So I wonder if there's any other therapy or treatment modules available other than this allopathic medicine. So I see there's a hope. I'm looking forward to hear from you in the next lectures that if there's anything available to do for these poor CKD patients. So thank you very much, sir. Thank you very much for your very important lecture. And I do believe that people who are missing it, they are missing something very important, which is going to have huge importance in their clinical practice. I think nobody should miss it. Nobody should miss it. Thank you again. Thank you very much.
Welcome, Dr. Professor Shibbir Ahmad, because he's a qualified doctor. That's why he, you see, he took very important hints from my lecture. That nocturia, this is very important. Nocturia and gradual development of anemia. So many people think bacteria is maybe due to his prostate, he will think, or he will think due to UTI or something. But it is a great and prominent symptom of CKD. Many people will not understand, but thank you very much that you got the point. Nice, nice. And I hope if you are present in our next classes, you will get a proper scenario of the whole thing and what is our homeopathic approach. I hope you'll stay in our class in next classes, and also I invite others. Don't miss this class. This class, I thought I am duty bound, because I think that I know something which I should transfer it to my colleagues who so and they are practicing. So this will benefit him and benefit his patient. This is software area. On this idea, I am doing this turmoil, doing this task to give this lecture. So don't miss it and ask other people to join so that they learn because when you are a practitioner, you will find this patient. They will come to you and our lecture will enlighten you to a better level. At least okay, thank you very much, Dr. Anwar.
জি, থ্যাংক ইউ স্যার আপনাকে এবং আমাদের প্রফেসর শিবির আহমেদ স্যারকেও অসংখ্য ধন্যবাদ। চমৎকার মন্তব্য এবং হচ্ছে যে আপনার আলোচনার যে চুম্বক অংশটি নিয়ে আবারও উনি আমাদেরকে গুরুত্বটা বুঝিয়েছেন এবং আপনি কত চমৎকার আলোচনা করেছেন সেই বিষয়টি উনি আমাদের সামনে আবারও উপস্থাপন করেছেন। আর আপনার কথার সূত্র ধরেই বলতে চাই, আমরা যারা শেষ পর্যন্ত আছি, কষ্ট করে ক্লাসের শুরু থেকে শেষ পর্যন্ত যারা আছি, আমার মনে হয় যে তারা অনেক লাভবান হয়েছি এবং যারা কারিগরি কারণে বা অন্য কোনো ব্যস্ততার কারণে অথবা একেবারেই ভুলো মনে আমাদের এখানে আসতে পারেননি বা যুক্ত থাকতে পারেননি বা চলে গেছেন, তারা অনেক কিছুই মিস করেছেন। এবং আমাদের পরিষদের যে সিদ্ধান্ত আমরা আজকে ক্লাসের শুরুতেই বলেছিলাম এবং স্যারও রিপিট করেছেন, আবারও বলছি, আপনারা নিয়মিতভাবে উপস্থিত হবেন। আমরা কন্টিনিউয়াম মেডিকেল এডুকেশনের যেই বিষয়টি পরিষদের পক্ষ থেকে সার্টিফিকেট দিয়ে আপনাদেরকে বা আমাদেরকে যে সমৃদ্ধির কথা পরিষদ জানিয়েছে, নিশ্চয়ই এটি আমাদেরকে অনুপ্রাণিত করবে, শুধু একটি সার্টিফিকেটের জন্য নয়, বরঞ্চ আমাদের যে ব্যক্তিগত সমৃদ্ধিটা আসবে এবং পরিষদের সাথে যুক্ত থেকে আমরা যে শিক্ষাটা পাবো সেটা আমরা আমাদের ব্যক্তিগত প্র্যাকটিসে যেমন কাজে লাগাবো, প্লাস আমাদের কনফিডেন্ট লেভেলকে আরো উপরে নিয়ে যাবে এবং বর্তমান সময়ের যে ডিজিজ গুলো আমাদের সামনে আছে, আমরা না বুঝার কারণে অনেক সময় অহরহ সেই কেসগুলোকে হয়তো ছেড়ে দিই অথবা না বুঝে কেসগুলো হাতে নিয়ে আমাদের রোগীদের অনেক বড় ক্ষতি করে দিই। এই জন্য আমাদের এই ক্লাসগুলো খুবই গুরুত্বপূর্ণ বলে মনে করছি এবং আমরা ডিএচএমএস ডক্টর, ডিএচএমএস স্টুডেন্ট, ডিএচএমএস ডাক্তার যারা প্র্যাকটিস করি, প্রত্যেকের জন্য আমি মনে করি এই অপরচুনিটি বাংলাদেশ হোমিওপ্যাথিক পরিষদ যে তৈরি করে দিয়েছে এবং ক্লাসগুলোকে আমরা বাংলায়, ইংরেজিতে এবং যেই ডিটেইলি আলোচনাগুলো তুলে আনা হচ্ছে, আমার মনে হয় যে আমরা এই সুযোগটা বাংলাদেশ হোমিওপ্যাথিক পরিষদ ছাড়া আর কেউ এখন পর্যন্ত করছে বা করার মতো ক্যাপাসিটিও বিল্ড আপ হয়েছে সেটা আমি মনে করছি না। কারণ বাংলাদেশ হোমিওপ্যাথিক পরিষদ স্বাধীনতার আগে থেকেই সাংগঠনিকভাবে কাজ করে আসছে এবং হোমিওপ্যাথদের কল্যাণে, হোমিওপ্যাথদের তাদের ব্যক্তিগত সমৃদ্ধি প্লাস তাদের অধিকার সংরক্ষণ, অধিকার আদায়ের বিষয়গুলো নিয়ে যেভাবে কাজ করছে, এত লম্বা সময় ধরে আর কেউ কাজ এখন পর্যন্ত করছেন না। সেই জন্য আমরা বলবো, আপনারা যারা এখনো হোমিওপ্যাথি পরিষদের সাথে যুক্ত হননি, তারা যুক্ত হয়ে সাংগঠনিকভাবে কাজ করবেন এবং নিজেদের মানকে অনেক উঁচুতে নিয়ে যাবেন বলে আমরা বিশ্বাস করি, আশা করি। আপনাদের কাছ থেকে সাহায্য সহযোগিতা কামনা করি, পাশাপাশি আমাদের জন্য দোয়া কামনা করছি। আপনারা আমাদের জন্য দোয়া করবেন এবং আমাদের যে স্যাররা আছেন, আমাদের সভাপতি, সম্মানিত সভাপতি ডক্টর শেখ ফারুক ইলাহী স্যার, বটক বৃক্ষের মতো আমাদেরকে যেভাবে ছায়া দিচ্ছেন এবং তিনি যেটা বলেছেন যে একান্তই সদকায়ে জারিয়া হিসেবে ওনার এই বয়সে হোমিওপ্যাথির উন্মাদনায় যেভাবে আমাদেরকে সময়, শ্রম, এবং কি বলবো সবকিছু উজাড় করে যেভাবে হচ্ছে হোমিওপ্যাথিক পরিষদকে দিচ্ছেন, হোমিওপ্যাথিক সোসাইটিকে দিচ্ছেন, নিশ্চয়ই আল্লাহ আপনাকে এই সরকারি জারিয়া থেকে বঞ্চিত করবেন না। এবং সবার প্রতি অনুরোধ যে ক্লাসে আমরা একদম প্রথম 10 মিনিটের মধ্যেই মানে 9টা থেকে 9টা 10 মিনিটের মধ্যে যুক্ত হবো এবং শেষ পর্যন্ত থাকার চেষ্টা করবো। অনেকেই ডিসকাশন সেশনে থাকতে চান না, থাকেন না, বা ক্লাসটা শেষ হওয়ার পরে পরেই চলে যান, অথবা মাঝখানে এসে আবার হচ্ছে চলে যান। সেটা আমরা যেহেতু আমি ক্লাসটাকে একদম শুরু থেকে শেষ পর্যন্ত অবজার্ভ করি, সেজন্য আমি বুঝতে পারি যে ক্লাসের একটা পিক টাইম থাকে, তখন হয়তো উপস্থিতি বেশি থাকে, শুরুর দিকে কম থাকে, আবার হচ্ছে একদম প্রশ্ন উত্তর সেশনে অনেকেই থাকতে চান না। অনেক সময় আমাদের অনেকগুলো মেসেজ থাকে, শেষ পর্যন্ত থাকলে আমাদের সবার জন্যই হচ্ছে যে বিষয়টা সুন্দর এবং কি বলবো, আমরা যারা ক্লাসের শেষ পর্যন্ত থাকি তাদেরও একটু আমাদের ক্ষেত্রে একটু অনুপ্রাণিত বা অনুপ্রেরণা থাকে যে আপনারা সবাই আমাদেরকে সঙ্গ দিচ্ছেন এবং ক্লাসের শেষ পর্যন্ত থাকছেন। সেই জন্য বলবো যে ক্লাসের শুরু থেকে শেষ পর্যন্ত এবং আপনার একদম পূর্ণ মনোযোগ দিয়ে যদি ক্লাসে উপস্থিত থাকেন, নিশ্চয়ই অনেক সমৃদ্ধ হব। এবং আমাদের এই ক্লাসগুলো শুধু আপনি কন্ট্রিবিউট করলেন, আপনার নামে আমরা হয়তো একটা পরিষদ যে উদ্যোগটা নিয়েছে সেখানে একটা সার্টিফিকেট দেব, সেটাতে সার্টিফিকেট আপনি হয়তো পেলেন, কিন্তু মনোযোগ দিয়ে যদি পুরো সময়টা না থাকে তাহলেও কিন্তু অনেক কিছু আপনি মিস করবেন। এই জন্য অনুরোধ থাকবে আপনারা ক্লাসের শুরু থেকে শেষ পর্যন্ত উপস্থিত থেকে একদম মনোযোগ রেখে, যারা ছাত্রছাত্রী আছেন, আমরা যারা আহ, উম, আহ, দুর্বল আছি, এবং আমি প্রত্যেকের ক্ষেত্রেই আমি ব্যক্তিগতভাবে নিজেকেও বলবো যে আমরা খাতা কলম নিয়ে যদি বসে একদম ক্লাসে যেভাবে নোট ডাউন করে আমরা পড়ালেখা করি, এরকম ভাবে করলে আমাদের ক্লাসগুলো আমাদের মধ্যে স্থায়ী হবে, আমাদের জ্ঞান আরো সমৃদ্ধ হবে। আল্লাহ রাব্বুল আলামিন আমাদের দ্বারা আত্মমানবতার সেবাকে আরো ত্বরান্বিত করবেন এবং বাংলাদেশে হোমিওপ্যাথি আরো জনপ্রিয় হবে। এটাই আমি বিশ্বাস করি ব্যক্তিগতভাবে, আশা করি আপনারাও এই বিষয়ে দ্বিমত করবেন না। তো আজকের মতো আমরা এখানেই শেষ করছি। সবাইকে আবারও আন্তরিক ধন্যবাদ, মোবারকবাদ, আমাদের ছাত্রের জন্য দোয়া কামনা, এবং সর্বোপরি আমরা আমাদের হোমিওপ্যাথির স্বার্থে, জনকল্যাণের স্বার্থে পিওর হোমিওপ্যাথিক প্র্যাকটিস যেন বাংলাদেশে আহ পরিচালিত হয়, আরো জনপ্রিয় হয়, সেই জন্য আল্লাহর কাছে দোয়া কামনা করবো, নিজেরা চেষ্টা করবো। সবাইকে আন্তরিক ধন্যবাদ। আসসালামু আলাইকুম রহমতুল্লাহি ওয়া বারাকাতুহু।
ওয়ালাইকুম আসসালাম ওয়া রাহমাতুল্লাহ। স্যার
কিছু বলবো জ্ঞানে মায়াজাম বিষয়ে যে আলোচনাটা আজকে হইলো, আমার একটা জট খুলে গেছে। সেটা হলো মায়াজাম মূলত কি? আমার তো যে সবসময় মনে হয় বিশেষ করে ক্যান্সার মায়াজাম, ড্রাগ মায়াজাম, অমুক মায়াজাম, এইভাবে আস্তে আস্তে আসলে রঘুনাথ স্যার যেটা বললেন যে মায়াজামেরও স্টেজ আছে, সেকেন্ডারি, টারশিয়ারি, হ্যাঁ, এরকম স্টেজ হয়তো ওই দিনেই হয়তো ক্যান্সার মায়াজাম, ক্যান্সার বা এইডস ইত্যাদি হতে পারে। কারণ আমি দেখছি, মানে নিজে কিছুটা চিন্তা ভাবনা করে দেখছি যে সাইকোসিস, যে সাইকোটিক মায়াজামের মূল কারণ হলো যে ক্যান্সার। আজকে যে মারণ ব্যাধি এইডস, এটাও এই সাইকোটিক মায়াজাম। আর এইগুলো তো সবার সাথে মিলিত হয়ে তারপরে এগুলো সৃষ্টি করে। আর শারীরিক বয়সের মধ্যে সেকেন্ডারি বা টারশিয়ারি স্টেজ, হ্যাঁ, এক একটা রোগ এমন সৃষ্টি হয়েছে। কারণ আমি এইটা এতদিন আমার কাছে মনে হচ্ছিল, আর সেটা আজকে স্যার খোলসা করে বললেন। আমিও আজকে কনফার্ম হয়ে গেলাম যে মায়াজাম মূলত তিনটে। হ্যাঁ, আর সোরা ছাড়া তো আর এই সমস্ত ওই সেভেন্টিক বলেন, সাইকোটিক বলেন, এইসব মায়াজাম তো আর সোরা ছাড়া আগাতে পারে না বা মানুষকে আক্রান্তও করতে পারে না। সোরা তো থাকবেই, সোরার সঙ্গে এটা গর্ভবতী আক্রান্ত করে। অনেক সময় দেখা যায় সোরার সাথে মিশ্র মায়াজাম, সেমিলিটিক মায়াজাম, তারপরে সাইকোসিস মায়াজাম একত্রিত হইয়া মারাত্মক রূপ ধারণ করে। এবং একটা স্টেজ বাই স্টেজ যত দেরি হয়, সিভিলিসে যেমন আমরা দেখছি ফার্স্ট স্টেজ, সেকেন্ডারি স্টেজ, টারশিয়ারি স্টেজ। এখন এই তিনটা সমন্বয় মানে গোল পাকাইয়া এর আগাতে আগাতে দেখা যাচ্ছে এই স্টেজ গুলো পার হতে হতে দেখা যাচ্ছে এটা একটা নামকরণ চলে আসছে, বিরাট বিরাট নামকরণ, যে কোনো চিকিৎসাই নেই। এই হলো এই মায়াজাম, এই তিনটেই আমি মনে করি। ধন্যবাদ সবাইকে। এটা আমার ক্ষুদ্র জ্ঞান থেকে আমি বললাম।